So why use an educational tool in the context of a patient preference study? Well, there are at least two compelling reasons for doing so. The first has to do with maximizing the validity of the data being collected. Accurate preference elicitation depends not only on patient understanding of the content and the context of the study, but some information about the disease state, an understanding of the attributes and the specific attribute levels, and an understanding of not only the choice tasks, but how to do them. A second important reason to include an educational tool is to reduce the likelihood that patients are confused or misunderstand a particular question, which in turn could cause a measurement error. Next slide, please. An element in selecting an educational tool concerns the modality. To date, most patient preference studies have used printed materials as a way to educate participants, but there's increasing body of evidence to suggest that digital approaches can offer some advantages in terms of improving participant engagement and motivation through a variety of different design features such as interactivity, and in doing so can assist in learner mastery of the preference construction tasks. Next slide, please. So in the lung cancer case study, we decided to develop a digital tool, an educational video that was guided by a framework based on empirical research and consensus recommendations from experts in the digital health research field. The educational module consisted of educational video consisted of 3 separate modules. The first focused on explaining the disease state and the 5 treatment attributes and their associated levels. Modules 2 and 3 instructed participants regarding how to articulate their preferences for treatments. Module 2 was focused on the discrete choice experiment, and module 3 on the swing weighting experiment. We did pre-test the video in a small group, 5 patients, and then there were some modifications and revisions made as a result of that pre-testing. Next slide, please. Here are some of the key features of our video. These included color graphics, interactive navigation. There was a voiceover, a variety of different icons were used, and then the content adhered to plain language principles that were written at an intermediate reading level. For those in the US, that would be approximately 6th to 8th grade reading level. And then some visualizations to demonstrate key learning points, as well as to enable patients to practice completing choice tasks. And to do that, we used a fictitious medication, a cold medicine, as an example. Next slide, please. Here's just a screenshot showing what the attributes, how they were displayed in the video. This is the Italian version. Next slide, please. And here's how the discrete choice experiment and swing weighting instructions were laid out in the video. On the left, this is a discrete choice, and on the right, the swing weighting. This is what participants would see. Next slide, please. At the end of the questionnaire, we had several questions about the participants' experience with the educational tool. The first of them concerned how helpful they found the tool to be. Next. And we found that the majority of participants found the tools to be either moderately to very helpful in assisting them in completing the choice tasks. There's slight difference in terms of country of residence. Italians reported finding the tool to be a bit more helpful for both discrete choice and swing weighting tasks as compared to their Belgian counterparts. Next slide, please. Thank you. And the second question concerned how easy did they find the tasks themselves. And in this case, again, we found that the majority of respondents across both countries found the two tasks to be between easy to very easy to both understand, to both answer and understand. Next slide, please. So by way of conclusions, we found that we were able to demonstrate real value in including educational video in this patient preference study. It had enhanced multimedia features that the majority of participants found helpful and expressed their satisfaction with using. I think probably a major strength is that this development of this video was based on a theory-driven and evidence-based approach, this EduGrid, which is our framework. But one caveat is important to note is that digital approaches such as developing a video do require longer development time and are more expensive than print-based tools. Next slide, please. And then finally, some comments about our limitations. We did not have a comparison arm, so we're not able to observe whether the use of our video-based educational tool was resulted in a superior comprehension on the part of participants who were assigned to that, exposed to that. And we did not assess comprehension per se. In fact, there's a need for further standardization and consensus regarding how comprehensive should be defined and assessed in the context of a patient preference study. And there's scope for further research on whether a framework such as the one we used indeed meet their intended outcomes. Next slide, please. So just by way of a few key takeaways, we know that patient preference construction can be influenced by the decision context, and that people construct those preferences as they go along in the course of performing the decision tasks. Factors that influence that preference construction include not only the decision context, but the framing of the choice task and the way relevant information is presented to them. And educational materials then play a key role in helping ensure that patients and participants really understand that decision context, really understand the choices that they're presented with, and understand what to do. In other words, how to perform the preference tasks.